Good morning, everyone. I'm very glad to be here today. And first of all, I'd like to thank the committee for inviting me and giving me the chance to share some knowledge about OCT, especially for glaucoma. Now, let me introduce myself. My name is Onassis Rocha Silva. I'm the head doctor and the founder at Clínica do Olho. I'm here today. Clínica do Olho is eye clinic in English. I'm here today on behalf of my clinic and also on behalf of Ophthalmology Society of Bahia. Now in the clinic we have 70,000 patients, including some thousand among glaucoma suspects and glaucoma patients. Before becoming a doctor, I went to the IT school and I'm very enthusiastic about using technology in healthcare. Those are pictures of Salvador. That's where I live and work. Salvador is the most African city outside Africa in the world. And our population is 80% African American. And we know implications about prevalence and aggressiveness of glaucoma in this population. This is very, very emotional for me. That was my great-grandmother. Her name was Raimunda. She was African American, very, very poor, and blind. And her story motivated me to become an ophthalmologist and take care of this population. People cannot afford medical insurance. People of all kinds. According to this picture from the glaucoma book, structural lesions takes place before a functional lesion. In the past, when we use perimeter to confirm glaucoma diagnosis, we have at least 50% of nerve loss. And now, using OCT, we can identify ganglion cells loss and retinal nerve fiber layer loss earlier than that. And according to the latest consensus about open-angle glaucoma diagnosis, OCT is the gold standard on detection RNFL thinning. And now we can make a glaucoma diagnosis without perimetry alterations. Let's take this exam as a normal exam. This is from a 55-year-old African American lady whose mother has glaucoma. Look here, the beautiful fiber layer in both eyes in the thickness map. And the whole black and white image in the deviation map in the optic disc report. At the center, we can see a normal ganglion cells report like an egg yolk here in the thickness map and almost black and white image in the deviation map. This is a normal situation. I will call this report as a traditional report. And as a routine, I perform anterior segmental CT. In this case, we have an open angle here and here. We can see the Schlemm's canal here. This is from the same patient from the previous slide. And I feel myself comfortable to conduct this patient without treatment and follow up this patient. I will follow up this patient. I'm following up this patient with one clinical examination plus one OCT per year. As you can see, we have the beautiful fiber layer here and here and here and here. And there is no color inside the change maps. Change maps are quite similar to the deviation map. Here we have a normal evolution without loss along 4 years. This is completely different from this case. This is from a 70-year-old African American lady with angle-closure glaucoma. Here in the third exam, we can see the big area in yellow as a possible loss, changing to a red area, a probable loss in the next exam. In the left eye, we can see a tiny lesion in the last change map, and we can see it in the thickness maps too. A 50-year-old African American gentleman. We suspect glaucoma by clinical examination. This patient came to me asking for eyeglasses prescription. In Brazil, ophthalmologists are responsible for eyeglasses prescription. It's their chance to identify asymptomatic disease like glaucoma. And in this case, I suspect glaucoma. And here we can see an alteration here and here. But note, this alteration are outside Bigerun's area. Note here. And we can see a normal, completely normal ganglion cells report. In addition to traditional reports, we can see an open angle in both eyes, including Schwab's line view and scleral spur view. This is another case, a 29-year-old Caucasian female with hypotension and migraine. Her ophthalmologist is a friend of mine who referred her to me to perform this OCT here. And in 2015, we can see this lesion here and here. And this year, we can see a bigger lesion than that. So my friend made a glaucoma diagnosis to her, and now this patient is being treated with 2 drugs. This is another patient. This is from 2008. When I used perimetry to confirm glaucoma diagnosis. And this is from a 58-year-old African American lady. I suspect normal tension glaucoma. As you can see, I performed 3 exams back then, and there's an increase in escotomas, especially in the left eye. I was convinced that this patient had glaucoma, but sometimes information from the patient can be misleading, and life imitates art. I quote Dr. House, everybody lies. So when I adopt OCT in her investigation, I could see the beautiful fiber layer here and here in both eyes. And I decided to stop the treatment and follow up this patient with 1 clinical examination plus 1 OCT per year. And as you can see, there is no color inside the change maps. There is no loss here and here. OCT requires a minimal cooperation from the patient, unlike perimetry. This is another patient, a 26-year-old African American young man with strabismus since birth, and suddenly seizures began in the last year. As you can see, there's an alteration here inside Bigerun's, but pay attention to this pattern. The key to the diagnosis lies in the ganglion cells, here and here. Note the big lesion, but this lesion does not cross median vertical line. And there is a perfect match between ganglion cells and perimetry. This is a neurological pattern. This patient was examined by a neurologist, and as you can see, there's a reduction in his right hemisphere of his brain. This is not glaucoma. Another way to use OCT, besides helping us to make a better diagnosis, is to show the patient their lesion, like in this case, a 61-year-old Caucasian female complaining of intermittent pain in right eye. If we analyze traditional reports, we don't get the diagnosis. But when we show the patient the image of angle-closure, in the same eye this patient complains of intermittent pain, we achieve the success in terms of diagnosis and therapeutics. In the end, that's all that matters. Let's see it closer. Here, easily we can see a touch between iris and the drainage area here. Patient with intermittent pain. This is from before laser treatment, and after laser treatment, open angle. This patient does not complain of pain anymore after laser treatment. OCT can also be used for identify plateau iris configuration, like in this case, I examined this patient last year. According to Stefan et al., we can use OCT for this purpose. In addition to OCT, we can use ultrasonic biomicroscopy, but this is not practical at all. So, in the past, when I used gonioscopy for this purpose, this condition was very uncommon for me. But now, using OCT, I can detect plateau iris at least once per month. A 55-year-old African-American lady with asymmetric optic disc. Note here and here, an alteration could mimic glaucoma, but note in the ganglion cell report, in the B scan, an altered anatomy of retina. This is due to a scar in the macula. Not easy to see the scar, but there's a scar here and satellite lesions. Probably this patient has toxoplasmosis. This is not glaucoma. This is from a 57-year-old diabetic African-American lady. Complains of intermittent pain in both eyes, especially at night. Family history positive for glaucoma, and including blindness. Again, if we analyze traditional reports, we don't get the diagnosis. We must remember Higgett, 1954, the dark room test for identifying angle-closure. And now we have technology to see what Higgett saw in the past. Higgett, and his name is very complicated for me to speak, Graham, 1910. And I call OCT dark room test. And let's see the first video from the right eye. Dark room, angle closure, lights on, slightly open angle, left eye, shallow anterior chamber, lights on, slightly open angle. So I made an angle closure glaucoma diagnosis to her, and I performed iridotomy in both eyes. And after laser treatment, there is no pain anymore. This is a very frequent situation in my state, Bahia. A patient with a large optic disc and a huge excavation. Look in the exam from the last year, a beautiful fiber layer in both eyes. Note the whole image in black and white in the deviation map. This is quite similar to the one from this year. And note the parameters are in gray. This means no data for comparison. Ganglion cells report completely normal, open angle. We should remember, Jonas, large optic discs have more fibers than small ones. This is not glaucoma. This is another patient, one eye blind. In this case, the role of OCT is to prevent a misunderstanding of diagnosis between neurological disease and glaucoma disease. Note here, there is no pallor in the optic disc, but there are broken eyes rule. Note alteration inside the germs, but the key to the diagnosis again lies in the ganglion cells. Note the big lesion, but this lesion respects medium vertical line. And there is a perfect match between ganglion cells and perimetry. This Brazilian paper explains exactly why the lesion appears in the same side, not in the opposite side, in the ganglion cells and in the perimetry. Look at this interesting case. This is from a 73-year-old Caucasian gentleman. This patient was referred to me to perform laser treatment, SLT. This is a good indication for glaucoma related to lupus, a pigmentary glaucoma. But note here, this is not typical of glaucoma. And note in the B scan in both eyes, an increase in retinal thickness. So I decided to perform a high-resolution cut, and as you can see, there is an cystoid edema in both eyes. This is a bilateral Ivan-Guest syndrome. This patient had a cataract surgery 6 months before this exam. And although a good indication for laser treatment, this is not a moment to do it. In this case, another case, OCT helped me to identify an early and correct diagnosis and take appropriate action. I'd like to show you all a testimonial from one of my patients.
Hi, my name is Andrea Monteiro. I'm 49 years old, and before I was having pressure in both of my eyes. I have a history of glaucoma in my family, so I decided to look for a doctor to see what my case was, and was found that the channel in my eye was a little closed. My doctor made iridoplasty and an iridectomy, and the pressure and the pain in my eye that was before in a scale 1 to 10 was 10. After the surgery is like almost 1.5, 2 at most. The comfort that I have right now in both of my eyes is unbelievable. So if someone that I know that need to do that, I will tell, do it, because it's really good. It's not painful. Like I said, I have my life back in a way of not have pressure or pain anymore. Or when happen, it's really rare.
Humanity has created this wonderful technology which has helped us to make a better and better diagnosis, especially for glaucoma. We need some adjustment in this technique in order to identify people who may go blind in the future. Imagine if this technology has existed when my great-grandmother was alive? Would have she gone blind? What do you think? Thank you.